So good afternoon, everyone. My name is Harindra Vijay. I'm the Vice President of Medical Devices at CADTH. And on behalf of the CADTH CEO, Dr. Brian O'Rourke, and our entire team here at CADTH, I'm very pleased to welcome you today to this Evidence to Action event, which is being live streamed as a webinar on the Canadian Medical Imaging Inventory. Before we get underway, I'd like to begin by acknowledging that we are in Mi'kmaq, which is the ancestral and unceded territory of the Mi'kmaq people. For those of you online who may not be familiar with CADTH, we are an independent, non-for-profit organization that provides decision makers at all levels of the healthcare system with objective evidence and expert advice on what they need to make informed decisions about the optimal use of drugs and medical devices. Our Evidence to Action series highlights the latest evidence and recommendations available from CADTH on drugs and medical devices on topics that are of interest and highly relevant across the country. We launched this series so that policymakers, clinicians, and patients can hear directly from clinical experts and CADTH researchers on what the evidence says and, importantly, what it means. Our focus today is on medical imaging. So appropriate and timely access to diagnostic imaging is fundamental to ensuring that Canadians receive high-quality care. The Canadian Medical Imaging Inventory is the most complete, up-to-date record of both medical imaging equipment and utilization across the country. This is the second iteration of a biannual report that CADTH has conducted. You can download the entire report from our website, which is at www.cadth.ca. So over the next hour, we have an outstanding agenda where we'll walk you through the evidence. First, CADTH staff, Lisa Pike and Andrew Morrison, will go over the methods that we used, our key findings, and trends that have been observed in medical imaging over the last decade. Then Kasia Kalinske will introduce and moderate our expert panel. So we're very fortunate today to have been able to assemble a panel with a truly impressive depth and breadth of expertise to delve deeper into the gaps identified and its implications. Following the presentations, you'll be able to ask questions, and for those of you online via the live stream player, you'll be able to ask questions at any time, and we'll convey those to the panel. So I'm extremely proud of the work that CADTH has done in this topic. I believe it fills a real need in Canada, particularly important in diagnostic imaging, as is a landscape that is evolving rapidly with potentially transformational new technologies, digital information, AI. Given this backdrop, an accurate, up-to-date, and comprehensive report such as this allows clinicians and policymakers to make informed decisions over the broad range of issues regarding medical imaging. I hope you find this information presented today useful. And now to get us started, please join me in welcoming Lisa Pike.
Just give me a second here to get this started. There we go. All right. Well, before we start, I would like to offer full disclosure. I am a medical radiation technologist, and I work for CADTH. And it is my great pleasure to be here today, right around the corner from where I started my medical imaging career at Victoria General Hospital. Just gives a bit of to how old I am. All right. So as Harindra kindly introduced, we are here today to learn more about CADTH's medical imaging inventory. As a foundation of understanding the landscape of medical imaging in Canada. With over 20 years experience in medical imaging, I certainly have witnessed incredible advances in the technologies that have both transformed the diagnosis and the treatment of disease. CT, MRI, SPEC, PET are commonplace in Canada now. Hybrid technologies such as SPEC CT, PET CT, PET MRI have enhanced this repertoire even more. And there's increasing demand for medical imaging given our changing demographic. But this trend is also paralleled by innovations that meet clinical need but are costly to install, operate, and maintain. As medical imaging landscape in Canada changes and new technologies become available, it's hard to know which equipment to use and how to manage that equipment with our finite resources. Given this, as Harindra indicated, it's critical that we have updated evidence around the medical imaging equipment that serves us in Canada. As a result, the 2017 update provides valuable insights into the trends to usage, trends over time, patient access, appropriateness, and service delivery. As Harinder mentioned, in 2015, the Canadian Medical Imaging Inventory began for the ongoing need for information. In 2017, the second iteration of the survey took place. And this is just one example of CADTH's tailored products. And we are here today to share the results of the CMI to help enable uptake of this evidence and highlight opportunities for further exploration around approaches to improved service delivery. And I encourage you all to take a look at the full report either online or these rather large booklets here and explore it with curiosity and collaboration in mind. As CADTH enters a new world into the HTM life cycle, it's really an opportunity to look for real-world evidence and how it shows up and what we can do to support each other in this very important work. Overall, the findings help decision makers to identify gaps in service, as well inform medical imaging related strategic planning on both a national, provincial, as well as territorial basis. It helps anticipate future growth for replacement and equitability. So the methods used for the 2017 survey included a web-based survey that data was collected between April and June of 2017. And this included a very comprehensive survey and data collection process that built upon the previous iterations of the survey. This year, the data was actually supplemented by diagnostic imaging equipment suppliers, and our results were validated by our jurisdictional customers and report reviewers. The 2017 report highlights 6 modalities, and it includes the number of units, their distribution, their volume of use, and the type of use across Canada. So again, I encourage you all to take a look at a deeper dive at this report. It also discusses changes over time, the age of units, technical characteristics, and Canada's status with other countries. And it also provides a deeper insight into the context of imaging in Canada. And I'd like to bring to your attention that this is just not a static report, that you can actually go into or ask for assistance, and CADTH can help you identify further details within the database if you're looking for other details, and I'll touch base a bit more about the technical characteristics that we were able to collect. Oh. Okay. So the purpose of the CMII was to help, I'm here. To help guide strategic planning, identify gaps in service, and help decision makers to anticipate future demands, as well to help facilitate appropriate use. And we're just going, here we go. And the CMI provides a view of access to specialty imaging equipment across Canada, as well the number and locations of this equipment. The results of the report, what we've been able to identify is that most machines are publicly funded and are predominantly used for clinical purposes, although some are also used for research purposes. The number of exams for each modality each year is also identified, and this helps us to understand the difference in access in different regions in the country, and it also helps pave the way for ongoing exploration. So the benefits of this data can help us to facilitate personalized patient care, such as localizing equipment such as 3T MRI or CT with angio or cardiac capabilities, perhaps also looking for open bore magnets suitable for claustrophobic patients or large patients. As well, this information helps us to inform appropriate deployment of new equipment and inform strategies aimed at reducing wait lists, and it also helps to plan for contingency care. So collecting data on the age of equipment is important because older and outdated equipment has a risk of failing or breaking down, which can obviously disrupt services, and it is becoming increasingly more difficult to find replacement parts for older equipment. And concerns are also raised around the age of or the upgradability, the clinical relevance of equipment, the reliability and performance, as well as safety and increased operational costs. So this biannual survey, so this was the second iteration, and it updates the database, and we again encourage our customers to take advantage and to connect with us because we're here to help to make sense of this information. Just making sure I'm on the same page. So understanding the utilization of medical imaging equipment in different regions of the country is also important, as what we've discovered is there's some jurisdictions that are able to perform more exams per 1,000 population with the same number of units per million population. And as an example of this, our colleagues at the Canadian Association of Medical Radiation Technologists shared with us that the CMI report helped them to highlight significant differences in access, particularly looking at Quebec's use of SPEC and PET-CT is more than any other jurisdiction in the country. And in the future, it's going to be important for us to better understand the reasons for such variations and look for opportunities for best practice across the country to reduce barriers to access. So the benefits of this information can help with system efficiencies by identifying overburdened and underburdened equipment. It can also help to identify equipment and maintenance and replacement needs, as well approaches, again, to consider how to reduce wait times, perhaps by diverting to underused sites. But with further analysis, of course, we can learn more about the factors that contribute to these efficiencies. This information as well can help with human resource planning, and we'll hear from one of our panelists later about some of the challenges to keep staff and students as, keep the skills and capabilities to use this equipment safely and to its capacity. As well, this information can be used to plan for contingency planning. It's very useful to know where equipment is being used for 24 hours a day if a piece of equipment breaks down and you need to divert folks to another place. So the technical data that we collected in this iteration was looking at equipment age, make and model, plans for new installation, plans for decommissioning or replacement, mobile versus static machines, and then very specific details around field strength for MRI, number of slices for CT, imaging scope for PET, as well as radiation dose management or those kind of controls that may be affiliated with certain equipment. So the CMII does provide us with information around the overall age of units and the relationship of that age to use. And the age of a unit was estimated by calculating the number of years since operation began. And the Canadian Association of Radiologists have guidelines that recommend the maximum life expectancy and clinical relevancy of any imaging equipment should not exceed 15 years. The age of PET-CT, which is the newest modality in clinical use, is consistent with this recommendation, suggesting that the transition from PET to PET-CT is complete. And in Canada, 2% or 2.4% of CT units and 3.5% of MRI units and 0.5% of SPEC CTs are actually older than 15 years. And a substantial percentage of SPECs at 21.4% are beyond CAR's recommended life expectancy. And overall, equipment in Canada appears to be trending a little older than the recommended, but as the CAR guidelines indicate, lifetime does depend on extent of use. So the CMII 2017 version also compares Canada's age of equipment with other countries, and then not just the age, but the number of equipment. And as an example, Canada ranks in the middle in terms of MRI per million as compared to other OECD countries. And we rank slightly below middle in terms of the number of CT and MR machines per population. And my colleague will speak to this a little later, a bit more. So this information can be found in the full report here or online, and I recommend people to take a deeper dive, as well as the database can be accessed for our CADTH customers by contacting CADTH, and we certainly are here to help. So medical imaging is obviously a hot topic for our CADTH customers, and as a result, we do have a wealth of information, assessments, and tools available that we've developed for your use. And it is not moving again. And so I suggest that, or I recommend that you visit our website, and we've gathered all this, all our medical imaging reports in one place so you can find the information easily, and I encourage you to take a perusal through there. As well, as I come to the end of my portion, I just want to highlight that the CMII does highlight several other questions around how medical imaging is utilized and regulated in Canada, as well as questions around equitable access, especially in rural and remote areas. It raises questions around cost effectiveness, and it also raises questions around approaches that can increase access with similar resources. And certainly there's further questions to explore around, perhaps how funding structures and payment models actually influence practice and access in Canada. And as CADTH enters into a health technology management approach, looking at life cycles for technologies and real-world evidence, I encourage you to visit our website or read the report, and with a very curious and collaborative mindset, because I think there's a lot we can do in this space. And so I leave you with these questions, as I am very pleased to introduce my CADTH colleague and part of the Brain Trust for the CMII up to the podium. I'd like to introduce Andrea Morrison, Program Development Officer with CADTH Medical Devices. Thank you.
Okay, so thank you very much. This one, is that this one? Yes. Okay, so I have 5 minutes to give you a whistle-stop tour of a decade of change. So what's happened to medical imaging in Canada from 2007 to 2017, relating specifically to the number of units and the number of exams in Canada. Oh, I'm missing a slide. So from at the highest level in Canada, sorry, there's a slide missing on this one. What we looked at is how many of the imaging modalities that we have actually experienced growth over the last decade, and 5 out of the 6 did. So SPECT-CT, we don't have it here, but SPECT-CT grew by over 646% over the last decade. And the next two actually are PET-CT and PET-MRI that grew at the same rate of 65%. But for the purposes of this presentation, that's where the similarities between these two imaging modalities end. CT experienced a 34% growth over the last decade. We are attributing some of this slow growth of CT to the fact that the market for CT may be reasonably saturated in Canada already. And finally, SPECT, it's the only imaging modality that we reviewed that has actually declined by 45% over the last decade. So now onto this slide. If we take a closer look at CT, we can see that, as I mentioned before, over the last decade, it has increased at the unit rate of 34%. But if we measure this at units per million people, the actual growth for CT over 10 years is 21%. Regarding the number of exams for CT, over 10 years they've actually increased at 65%. But if we look at this per 1,000 exams per 1,000 people, this translates into a 48% increase. Now, if we look at CT at the provincial level, comparing the 2 years, 2007 and 2017, a number of things come to mind. Well, first of all, we can see that 3 provinces didn't experience any growth in the number of CT, but they stayed the same. And also 2 provinces, Ontario and Quebec, account for 60% of all the growth in 2017 and also all the growth in 2007. I should add too, I'm not sure if Lisa mentioned it, that CT is the only imaging modality that we have in Canada that's available in every province and territory. Now, if we look at CT through the lens of units per million people, a different image emerges. And so we can see here that over the last 10 years, within 4 provinces actually experienced a decline in the number of CT units. So it provides a really different perspective. And then if we look at the number of CT exams per 1,000 people across these provinces, we can see that 3 provinces actually experienced a decline in the overall number of exams, even though the country as a whole experienced growth of 48%. As Lisa mentioned, if we compare Canada's exams per 1,000 to other OECD countries, we currently rank for CT in between Estonia and Slovakia. Now, moving on to MRI, overall there was 65% increase over the last 10 years regarding the number of units. But if we measure this by units per million people, this translates to a 47% increase. And if we look at the number of exams, overall there was an 80% increase in MRI exams over the last 10 years. But again, if we measure this, exams per 1,000 population, we see that this amounts to a 58% increase in exams. Again, if we look at the MRI across the provinces over the last 10 years, we can see that one province had the same amount of MRIs over the last 10 years, and the rest experienced growth. If we put this through the lens of units per million people, we can see that actually they all experienced growth. And if we go back to this, this last slide, we'll see again that Ontario and Quebec experienced 60% of all the growth for 2017 and actually for 2007. And I should mention on this slide here, while one province experienced a decline, three provinces actually doubled the capacity of MRI per million people. And if we look at MRI exams per 1,000 people, we can see that actually every province gains and all experience different measures of growth over the last 10 years. And if we compare Canada to other OECD countries, we know that we actually we're sandwiched between Chile and Latvia in terms of number of exams. Now over to PET-CT. Like MRI, it experienced a 65% growth over the last 10 years in terms of number of units, but overall, and that per million people translates into a 56% increase. We can't provide a comparison on the number of exams because CMII didn't collect this data in 2007. Overall, we can see that there's a patchy landscape for PET-CT in Canada over the last 10 years at a provincial level. But as you can see, Ontario and Quebec experienced 74% of the overall capacity for PET-CT in 2017 and about 69% in 2007. I was at a conference a few weeks ago, the CAMRT and the CANM conference, where somebody mentioned conversationally that PET-CT in Quebec intends to add 15 more units over the next year or so. If they do that, they will have 2/3 of Canada's total PET-CT capacity. And here is the view of PET-CT at the million population. And over to SPECT-CT. SPECT-CT is the imaging modality that has experienced the 646% growth, which, if you measure in terms of millions of people, translates to 63% growth over 10 years. Again, CMII didn't collect data on the number of exams, so we can't provide a comparison for that. As you can see here, by the number of units, every province experienced growth in Canada. And the same here. Actually, one province experienced a decline in overall units per million people. And onto SPECT. SPECT's the only imaging modality that we reviewed that experienced a decline over the last 10 years. I should point out that while we did SPECT has declined quite dramatically, in 2007 there were more SPECT than CT and MRI put together. And even now, there's more SPECT than there are SPECT-CT and PET-CT put together. So in many respects, it's still considered a workhorse in nuclear imaging, but it's certainly declined in the number of units. And with that, I'll pass it over to Kasia. Thank you.
Good afternoon. I'll be moderating the panel discussion portion of the event, so I please welcome our panelist members to join us at the front. And if you could please sit in the order that is on the screen with Karen sitting here. I think that will help the audience keep track of who's who. And during the discussion, there will be an opportunity for questions from the audience in the room and also online. And I see that we have a lot of people listening in today from across sectors, from government, industry, academia, and various associations. Our discussion today will be fairly broad in scope, so I think there will be something of interest for everyone. Also, we have an outstanding panel of guest speakers, and I'll introduce them briefly, and I welcome you to read their full bios on the Symposium app. So first we have Karen Fader. She is a faculty member in the nuclear medicine program at the Dalhousie School of Health Sciences. Karen's research interests have concentrated on the implementation of the evidence-based decision-making process in teaching and learning. Most recently, her research is exploring how the integration of health informatics in the diagnostic imaging setting can improve the delivery of healthcare. Karen holds a Bachelor's of Health Sciences and a Master's in Health Informatics from Dalhousie University. As president of the CAMRT, which is the Canadian Association of Medical Radiation Technologists, Karen has focused on building research capacity and culture across the MRT profession. Dr. Greg Butler is a radiologist and a senior medical director for diagnostic imaging at Nova Scotia Health. After graduating from Dalhousie Medical School and completing his radiology residency at Dalhousie, Dr. Butler worked in diagnostic and interventional radiology at Valley Regional Hospital in Kentville, where he also served as chief of staff. Dr. Butler has also held appointments at Hamilton Health Sciences and Stanton Territorial Hospital in Yellowknife. Interestingly, Dr. Butler established the first teleradiology link to the Northwest Territories. He has held many leadership positions, including Doctors Nova Scotia, Canadian Association of Radiologists, and the Radiological Society of North America, just to name a few. He is also co-founder of the imaging informatics company Real Time Medical, based out of Ontario. It was difficult for us to find a radiologist who was available to take part today, so we are very grateful that Dr. Butler accepted to join us today on very short notice. So thank you for that. And next we have Tanya Dickey. She joins us from Prince Edward Island, where she obtained a Bachelor of Business Administration and Bachelor of Applied Sciences in Radiography. She pursued her diploma in MRI at Red River College in Manitoba before returning to PEI, where she worked as an MRI technologist. Currently, Tanya holds the role of Quality Risk Coordinator for Diagnostic Imaging at the Nova Scotia Health Authority. Tanya is also currently serving as the Acting Director for Diagnostic Imaging on PEI. Tanya has volunteered for the CAMRT as well as taking on several roles on the PEI AMRT. Thank you, Tanya, for being here. And Susan Delaney. Susan began her career as a radiological technologist at the Victoria General Hospital here in Halifax. She has a Master's of Health Services Administration from Dalhousie and is a certified member of the Canadian College of Health Service Executives. In 2016, she accepted the role of Senior Director of Diagnostic Imaging for the Nova Scotia Health Authority. Susan has worked on various committees at the CAMRT, as well as the CADTH Medical Isotopes and Imaging Modalities Advisory Committee. Thank you very much for being here. So I very much look forward to hearing your perspectives and opinions. As we heard, there have been a lot of changes over the past decade in medical imaging in Canada. So my first question is, in your experience, what are the drivers of change in medical imaging? Susan, would you like to start?
Okay, so the drivers, I think, are expectations of the clinicians who provide care for patients around the country. They're always interested in new technology, and so they're always pushing us to acquire new technology. Pushing is probably the wrong word. They're supporting us to acquire new technology for our patients.
Tanya?
Sorry. Some of the drivers in healthcare, I think, are that some of the clinicians are performing a different style of medicine than perhaps we've seen in the past, using less physical exams and requiring or depending more on diagnostic exams or the results of diagnostic exams to make decisions on what they'll do for their patients. And sometimes as well, with limited access to specialists, they're asking for exams before patients set foot through the door.
So another driver, I think, for us in medical imaging is research. There have been tremendous breakthroughs, as we know, MR, CT, PET, and so forth over the years. As these modalities appear, industry, of course, gets a hold of them. There's a lot of R&D that brings out really quite miraculous tools. Often the medical profession is in a position of trying to catch up. Now we've got this tool, what the heck are we going to do with it? Research, the importance of research in our profession in diagnostic imaging can't be overstated. We need more research, we need more evidence on the efficacy of the tools that we have. To pick up on what Tanya said, another thing that's happening in health is the volume that we're being driven by. We have a huge number of people, a huge number of diseases, a huge number of expectations from patients, from the public, from providers, to do more and more by way of diagnosis. An example of what has driven CT in my career in radiology is the emergency rooms. We used to, in emergency rooms years ago, wait and see with a lot of patients. A patient presents with belly pain. We don't really know whether it's important or whether it's going to pass. So we hold the patient in an emergency room for 24 hours and see whether they get sicker or better. We don't have that luxury anymore. The emergency rooms are backed up, as we all know. We have an immediate need to diagnose right away. And some of the tools like CT are miraculous in doing that, in triaging patients. You're sick and you're not. And so there's a tremendous demand. As some may know, the demand for after-hours imaging has gone through the roof. And the reason for that is that we can't wait until tomorrow morning to decide whether a patient is sick or well. One other driver is our aging population. We know that people are living longer. People are expecting, and so they should, better care, and they expect to live longer than before. And we need advanced diagnosis to be able to offer appropriate therapies. So all of these things contribute, and we are going to see continual growth in imaging in the future. One of the things I noted about CT is growing. It's not growing quite as quickly as it was. I think you're going to see another spike in CT. And the reason being, I think CT is going to start to take over the role that conventional radiology played in the past. University of Toronto right now is embarking now on some research to see if the chest X-ray has come and gone as a diagnostic tool. If chest X-rays no longer are done for patients, we're going to see CT now emerging as the way you image a chest. They're also looking at another research project on abdomens. We may not be doing plain films of the abdomen in the future. So there's lots of different drivers and influences on our system.
Thank you. Karen?
Just to expand a little bit, in my personal experience, the largest driver is industry. I know you suggested that, research and then therefore manufacturers come up with new tools and toys. I would suggest that it's really industry finding new ways to either through software or through hardware to expand medical imaging. And then we are left in a position of catch up, and we are then left in a position of what research do we need to do to demonstrate the efficacy of this equipment. So for me, in my experience, it's really been industry that's been the greatest driver in our change in technology and therefore the impact in healthcare for medical imaging.
So in terms of demand, is the demand for the latest and greatest, or do people prefer what's tested and true?
I would say it really depends on where you are. So if you're in more of a rural location, it may be more tried and true. They're happy with what they have. This is what they want to continue with, and maybe there isn't that same sense of the need to go out and learn and do something more or have different pieces of equipment. On the flip side of that, you will have other centers where they are considered the center of excellence, and yet they don't have the newest piece of equipment that can do the things that they would like to be able to do in terms of imaging of patients and patient management. So I think it really depends on where you are and what the demand is in the center.
And so I think demand also comes from patients who, I don't know about you, but if you have a symptom, we're on the internet, we're looking it up. We have patients who are out there looking to see what is the treatment of the day for a particular disease, and then they lobby government to either send them to where that treatment is available, or why don't we have it here? So I do think that patients and their expectations, and we're dealing with a much more informed and educated public these days than we ever had before. So they're not waiting for their doctor to refer them. They're going and doing the research themselves and going to their physicians and saying, okay, how do I get this? Because it's better for me, or it gives me a better chance.
Along those lines, is there greater awareness among patients about radiation exposure and greater concern?
I think in some cases there's more awareness about radiation exposure. I'm not sure it's always necessarily good awareness. We've seen a lot in the mammography world of patients sometimes not wanting to opt out of the standard mammogram and wanting to go right to an ultrasound or right to an MR instead of following sort of the way the typical pattern follows for those patients. And sometimes, in some cases, depending on the age of the patient, it may be appropriate to go beyond, but sometimes the patients, even depending on their age range, still want to move a step ahead to avoid the radiation. But I also think at the same time, we aren't looking at the radiation safety of things, although the dose of a lot of things has gone down in CT and in plain films. We're still doing more imaging than we ever were before. So people are having, although lower dose perhaps exams, they're having more of them.
If I could just speak to the question of people's acceptance of diagnostic imaging, we have to remember that we're in a technologically driven world now. Everybody's got a smartphone, everybody's got a smart television, everybody's on the internet, and there is an increasing, I think, interest and confidence in technology. And diagnostic imaging represents truly the most visible advances in medicine that the public understands and the public sees. There is something very consoling about being put into a multi-million-dollar machine. Somehow you feel that you're inevitably going to be better served if you've had that scan. This is one of the reasons why appropriateness and utilization based on best practice and our knowledge of what does patients really good is challenged by the fact that everybody wants a scan. And I have colleagues who are family practitioners who will say, when a patient comes into my office, they want one of two things. They want a prescription for drugs, or they want a requisition for some fancy scan. And if the doctor says, you know, quite honestly, a scan is not going to help you, a lot of patients feel let down. They feel that they haven't been well served, that what's the point of having all those fancy scanners at the hospital? When I need one, the doctor tells me no, that he won't do it. So this is a challenge for us. Technology does not hold all the answers yet. Technology, in my view, and it's personal, will hold a lot more of the answers. Not about God, not about the difference between good and bad, but in terms of solving some of the riddles and mysteries of our biology and our disease, I think technology eventually will solve all of them. And that brings us to artificial intelligence, and I do want to talk about that at some point and the huge impact that that is going to have on our societies and on diagnostic imaging. But maybe we can leave that for a minute.
That is definitely a hot issue in medical imaging right now. We could move to that. Any other comments, though, first about the other points that were raised?
Other than the fact that patients here don't seem to have the same, other than mammography, I agree, they're concerned about radiation, but I don't think people really see medical radiation as a big concern if you look at the number of CT scans that we do. I think we'll gradually be pushed more to that direction as the standards, the accreditation standards evolve over time. You know, right now we're asked to look at diagnostic reference levels and doses, the lowest reasonable dose for patients. I think that's coming in Canada. It hasn't pushed forward as quickly as it has in the US, particularly in places like California.
In terms of educating the public around radiation exposure, I think MRTs are in a unique position as we are the ones that touch the patient. And so whether you are a radiological technologist or a nuclear medicine technologist, these are the questions that we often get from patients. And so we need to make sure that we are prepared and able to address those concerns. And as Stephanie and I like to say, we like to help patients put it in perspective. And to do that, it has to be part of the MRT education.
Thank you. Okay, and in terms of artificial intelligence, is that a consideration for education for the next generation? Or is that already playing a role in the trends that we're seeing in the past decade?
So I brought it up. So, in my career, which spans now 38 years in radiology, I saw the evolution of CT and the belief that CT was going to answer all of our questions in imaging. It really was a revolution. It was incredible. I saw the first picture of the first clinical MRI examination. It was displayed in Chicago at the RSNA in about 1982. Now the flavor of the month for radiology is artificial intelligence. However, in my own view, and it's a personal opinion, it's really different this time. Artificial intelligence really is something different. Machine learning and deep learning are going to affect all aspects of our society and quicker than I think people realize. In the diagnostic imaging field, there was an article in Radiology this month, our premier journal in radiology, once again visiting the issue of whether AI is going to replace physicians. And I'll tell you what our stock position is as radiologists. It will only enhance our role. Because instead of us now doing some of the drudgery of, saying there's a fracture, it'll find all that stuff. We're going to be now more focused on what is the meaning of 4 pulmonary nodules in the lungs. And so very, very celebrated radiologists, some of whom I know personally, are going on record as saying, don't worry about AI. For those who embrace it, it's going to be great for our profession. I can only give you my own view. And this is a personal view and not one that's been born of a lot of research, although I've been exposed to a fair number of talks on AI. AI is so powerful and it is developing so quickly that the need of human eyes and a human brain to interpret diagnostic imaging of the future is going to become absent. In addition to that, I also, in looking into the future, things like PET-CT that we've seen now sort of expanding as being very important, and it is very important. And it's important because SPECT-CT gives us biological, molecular information. It's kind of, we use a surrogate, FDG, we use glucose metabolism as that surrogate. But it gives us information about whether cells are cancerous or not. But there's a new emerging technology called molecular imaging. MRI is really the kind of the glimpse into the future of molecular imaging, because MRI does characterize tissue in unique ways that CT can't, for example. You combine molecular type analysis with the power of a brain like Watson, IBM Watson, and suddenly images become irrelevant. What I was trained to do was look at patterns, be able to look at a picture and be able to pick out a story that will lead me to a professional opinion that the patient has this problem or that problem. That whole art, I think, is going to become unnecessary and irrelevant. I think AI systems of the future are going to be able to very, very accurately say, you've got a 92.6% chance of a small focus of adenocarcinoma in the head of the pancreas. And I think that's where we're moving. How fast we're going to get there, I don't know, but my gut feeling is it's going to be sooner than people really anticipate. In the short term, AI is being now applied to computerized automated diagnosis systems whereby abnormal patterns can be detected, picked out of data sets, pointed out to professionals, and we then can be helped to see these patterns and then make an informed decision as to what the patterns mean. But I think more so in the future, I did see Watson. I met IBM's Watson at a meeting last year. Watson, of course, is not a single entity. It's a pile of computers working away in various parts of the world. But what Watson is doing right now is Watson is looking at images and correlating the results of those images with other physical findings, with professional radiologists' interpretations, and with autopsies or biopsies. Watson is getting increasingly smart at what signs on images really mean. So is AI a revolution? It absolutely is, and no wonder the journals in radiology are full of this. How is it going to affect us in Nova Scotia or Ontario? It's not going to affect us much in the near future, but in the longer future, we may be looking at 10 years. I think AI is going to have a profound effect on how we do business in imaging. There are lots of other changes that we are going to see that we could talk about, and I don't want to sort of go on, but there are other things, cloud computing and centralization of radiology resources, which through teleradiology, which are coming. Subspecialization in radiology is another important issue, but we'll leave that maybe for another day.
Yeah, I'm curious to hear the other panelists' thoughts. Do you think this is a big driver of change?
I think it will be. I mean, we've been using CAD in Nova Scotia for a number of years now for mammography. It hasn't really taken over, but the bottom line is, you're right. It looks at pattern recognition, and then a radiologist makes the decision. But I do think that with the advent of computing power, with the advent of machine learning, it's certainly going to challenge professions like radiology. Although one of the things that's happened in radiology that we haven't really talked about is the move from strictly diagnosis to intervention. It's a huge change now. If you look in our departments, we don't just diagnose, we treat patients. We do coiling to block aneurysms so that we don't have to do surgery to clip the aneurysm. We deliver targeted chemotherapy to lesions to avoid a patient having systemic chemotherapy. I'm thinking of EVT for stroke, where a patient who, I went to a talk last Thursday, and I've been to this physician's talk a number of times, Dr. Shankar, who has a patient who, believe it or not, was 91. It's an older lady. She was completely paralyzed on one side when she went on the table, and before he even finished the procedure, started moving her arm, and the next day she got up and was able to walk, and really no deficits at all. So I think that radiology is changing, there's no question, but I think the focus is moving away from strictly diagnosing disease. And Dr. Butler, you can comment on this as an interventional radiologist, and how you've seen that improve the outcomes, minimally invasive procedures that really improve patient outcomes and reduce morbidity and mortality.
Absolutely. Minimally invasive techniques, which radiology has pioneered since the days of Charles Dotter, who pioneered angioplasty and intervention on blood vessels. it's been tremendous, the growth. One thing that I will say, though, that the better it gets, the more interested our colleagues in other specialties are in it. So, for example, in the United States, we've seen a massive movement away from radiology and into, guess what, cardiology, of all things. Cardiologists have become increasingly interested in non-invasive treatment of blood vessels, all techniques that were really designed and originally researched by radiology. Dr. Grunsig, mind you, did invent the balloon angioplasty catheter for coronary disease. So Susan is right. Here in Halifax, we do see now neurosurgeons doing and interested in some degree of catheter work. We see vascular surgeons as well. So it's going to be, I think, a hybridization between radiology and other specialties. But catheter and minimally invasive techniques are absolutely the way of the future, for sure.
And we're seeing hybrid ORs that combine a number of modalities with open surgery to be able to treat patients, and we'll have one in Halifax in the not too distant future. So bottom line is, you're right, other ologies are very interested. We do a lot of procedures in collaboration with other specialties. These other specialties actually spend time doing this work as residents, so certainly that's another impact on radiologists that I think is going to be changing the future.
Karen, do you have a comment?
Yeah, it ties in a couple of things. AI, 3 or 4 years ago, was a little tiny piece. If you went to a large conference, there was, just a couple of talks on it. And now if you go to the larger conferences, RSNA or ECR or SNMMI, it takes up a huge portion of what's being discussed. So I would say it has grown exponentially in the last few years. I was asked a question in terms of AI. I was being interviewed, and it was around, so, there's some concern for radiologists who may be, losing their practice because of AI, but, the technologists, they'll be fine, right? Because you'll always need the technologists. And I said, it would be rather naive of us to say, because we're the hands-on touching of the patients, that it won't impact us in any way. I believe it certainly will. It will impact our practice tremendously. It will impact what it is that we are going to have to do on a daily basis on the fly. I think it will also impact us in terms of, who's to say that we've all been in backscatter machines at the airport. Who's to say that there wouldn't be a Watson talking to us that says, step into the tube, raise your arms, hold your breath. Thank you, you may leave now. And where's the MRT there? So, I think we can't be naive about this, and I think it's really important that we work collaboratively to figure out what the impact AI will have on the practice of radiology and diagnostic imaging together.
Thank you. I'll just take a pause right here to take a couple questions from the audience. So I see one came in online. The question is, what strategies can be employed to ensure appropriateness of imaging? And related to that, what is the role of the technologist and of the radiologist? Tanya, would you like to start?
So I think appropriateness is a really tough one to answer, because it's not just any one person or any one area that's responsible for appropriateness. You can look at the radiologists sitting in their office and prioritizing things. You can look at the technologists on the floor, whether they should be sending stuff away. But then you have to look at the clinicians who are referring things along. And then you have to look at the patient. Again, we've talked about how much more educated the patients are in this day and age. A lot of them have done their research. They've gone to Dr. Google. They've Googled up whatever they think their issue is, and they've come to the doctor's office with a clear outline of what they expect will be done for them. So how do you make it all work? How do you get the appropriateness when you have somebody coming through their door with a very set expectation for what they want? And then how does the clinician deal with that? And further to that, then where does it fall on the doorstep when they come through the doors at radiology? Does it fall with a clerical staff who's trying to check them in? Does it fall with a technologist on the floor? Does it fall with a manager? Does it fall with a radiologist? It's a really tough question, and I'm not sure what the answer is, but it's certainly a very large issue which is going to require more than just one piece. There's going to be education to the public, education to the clinicians, and of course you have to have the CEOs, people who run healthcare, on board as well for some of the kickback that you might get if you're trying to slow the way for people.
And I would say that it even goes a step further upstream to the clinicians who are ordering these tests, because we have a great opportunity in Nova Scotia with a new information system, one person, one record. Do you build decision support into that in the physician office to be able to help them make the appropriate decision on what's the next step for the patient?
Thank you.
Appropriateness is difficult to do. And Canada, it's a country that is known to be great at developing guidelines, including appropriateness guidelines, so-called referral guidelines for diagnostic imaging, has been really slow to implement. We don't have a lot of appropriateness initiatives in Canada. It's hard to do because there's pushback, as mentioned, there's pushback from the patients who don't understand why they're being denied a test. There's pushback from the doctors who are pressured to kind of move things along, and if a test will satisfy this patient, then let's do it. Or lack of information. Well, I've always done CT scans on people with headaches, or I've always done one of the big ones right now is low back pain. I mean, low back pain it's a epidemic, and it's very easy to kind of satisfy patients by saying, you know what, I know this is hurting you a lot, and I take your symptoms seriously, and we've got to get imaging on this, when in fact it's been shown that in many cases imaging doesn't help. In fact, it aggravates the problem, because then it potentially gets a patient a mindset that there is something there that needs fixing, when in fact it may not. So appropriateness is a huge challenge. As Susan mentioned, there are going to be new IT opportunities with so-called decision support at the electronic order entry level. We are embarking on some appropriateness initiatives this year in Nova Scotia in conjunction with Choosing Wisely. Choosing Wisely is a great initiative. It cuts across all disciplines. Everybody's involved. They have a great publicity campaign. It's good. Choosing Wisely is appropriate, and we endorse it, and we're going to try to work with them to get started with appropriateness, to make sure that we're maximizing the utility of all of this infrastructure we have to do the right examinations for the right people at the right time.
Thank you.
Yeah, I'd just like to say that I think appropriateness rests with each individual professional who is part of the process. So from the technologist to the radiologist, all the way up through whoever, and the referrer, of course. But I think we all have a responsibility for appropriateness. It doesn't rest with one professional, in the same way that when you look at any other process, multiple steps or multiple sets of eyes always improves the process. So that's what I would say to appropriateness and where it rests.
I know that was good.
Any other questions? Oh, another comment?
Just talking about the Choosing Wisely criteria, back on PEI, we have been working towards some of the Choosing Wisely criteria, in particular the low back pain, sort of a low-lying fruit, and working mostly on the plain film imaging for low back pain. And we have found, with very dedicated effort to that one small piece, the biggest thing that we have done is actually send a letter back to each referring physician who sends one in. We do the exam, but we keep the requisitions and we send them back to the doctor with a note basically saying, we did do your patient today, but just in the future, we are trying to choose wisely, and, we hope that your patients will fall within the guidelines. And we have found that it has dropped the number of requests for low back pain, but the requests in every other area go up. So it's a tough battle.
So in terms of implementation of guidelines, even when we try to implement them, as you suggest, it's really hard to determine whether or not they're being enforced, whether they're being followed. Using health informatics and changing the way that we collect data, if we can do order entry with clinical decision support, then we're able to go in and do some analysis, some deep diving, and figure out who is it that's still ordering these tests and why, and then we can help to educate them. So I think health informatics and putting practices in context will be very helpful when we have that kind of data to actually provide evidence to say, do you realize that you are still the only physician who is ordering, 70% of these studies?
And on PEI, we've done exactly that. We do physician report cards. We've just now completed our second set of them, and we send them out and we compare them to their peers in their same area as to how they're doing. And we found for the low back pain that there's really a few offenders for the vast majority.
I'll mention one more thing, and that's a personal peeve of mine, and that's the 30% figure. So everyone here has heard that 30% of diagnostic imaging is unnecessary. And I want to tell you that from my point of view, this figure is unsubstantiated. There's no data to support the fact that 30% of imaging is unnecessary. It's been quoted many times, and it keeps getting refreshed every few years because somebody says it again at a meeting, and then somebody quotes that person instead of the person 15 years ago who made this observation at a talk in the United States, because somebody did trace it back. Where did that 30% figure come? We really don't know what percentage of diagnostic imaging is inappropriate. That is, it has no bearing or positive effect on a patient's outcome. But we do know that there is at least some. That's pretty well, everybody agrees we're doing too much. But how much more than we should be doing, we can't say that. We do know as well that electronic order entry and application of proper referral guidelines does decrease utilization. We know that as well. How much is it going to decrease it? Well, people say around 12% probably is a reasonable target. If you could get utilization reduced by 10%, you probably have gotten a significant part of at least the low-hanging fruit, the real blatantly unnecessary imaging that's going on. And that's initially with appropriateness and applying that. If we could get a 10% reduction, we would be thrilled. And that's the kind of targets that we're going to be setting for ourselves initially, and we'll see where it goes.
Any other questions from online or in the room? Yes?
All of the advances in the future. Oh, sure. All of the advances that you're talking about, the future potential for artificial intelligence, are great if you have access to that new equipment and seeing all of the emphasis around MRI, CT, SPECT CT. But in a country like Canada, where so much of the population is in outlying areas, relying on that local health center or hospital that has an X-ray at best, when I hear you specifically talking about the potential of X-rays being, for the chest X-ray being replaced by the CT, it does make you wonder what the future holds for not the majority of our residents, but all of those residents who don't have ready access to larger facilities. So I guess my question is, what can we do to try to, as imaging advances, what can we do to try to be continuing to improve the access and quality for patients in remote areas? And I'm wondering, I think I heard some mention of some distance imaging or teleimaging. Is there something out there that will not leave the rest of that remote population behind?
Yeah, so you raise good points. Accessibility to diagnostic imaging really relates to a few things. One is the equipment itself that acquires the data. There's nothing much we can do about that, in that if you need a CT, you need a CT. And if the CT is some hours away, well, we've got to figure out as a country what is acceptable, what is an acceptable distance for somebody to travel. We do know now that people who live in remote areas already have certain risks that are inherent with living in a remote area. If you have a ruptured aneurysm, in our community of Kentville, there's a vascular surgeon on call 24/7 who can save your life. But if you are in Grise Fiord in the Northwest Territories and you have a ruptured aneurysm, you've got a problem. And there's really nothing we can do to make absolute equality across such a vast expanse for our patients. But there must be reasonable goals that we can achieve. Now, in Nova Scotia, we have what we think to be a good number of magnets of MRI in our province. And nobody in Nova Scotia really has to travel more than, what, 2 hours maximum to get to a magnet?
That would be the maximum.
Yeah, whereas we were visiting recently, we were up to a hospital at Thunder Bay, and in Thunder Bay there are folks in Northern Ontario that have to travel 7 hours to get to MRI. So is that an equitable distribution of imaging? Probably not, and we really do have to think of what is reasonably acceptable for people. So that's on the equipment side. On the interpretive side, everything now, images are distributed at the speed of light anywhere in the world. We have access, if we are going to be employing advanced artificial intelligence systems, those are also cloud-based. Those are available to anybody, anywhere, anytime, if you've got internet. So those kinds of things are really exciting, and teleradiology has had a huge impact, I think, on accessibility of patients to radiologist expertise. It's just absolutely, it's thrilling. It puts chills down your spine to realize that you can be somewhere remote, no radiologist in sight, and yet have a radiologist, his or her eyes and mind and expertise right there for you at the speed of light. And that's only come into being in the last 20 years. This is, you know, amazing new technology. So there are those two different aspects: the physical equipment, which, you know, it has to be what it is, but then the informatics and the distribution of expertise, medical expertise in the imaging sense, is really already there. Now, as you may know, I mean, we're looking at remote surgery. That is coming along. There's going to be a time when surgeons are going to be able to perform operations at a distance, and that technology, you know, is well developed and is well beyond its infancy. So that's kind of exciting for the future too. I mean, it's almost
a whole other conversation. Yeah, I'd love to keep going, but we're almost out of time. Just in the last few minutes we have left, I would like to ask, how can the CMII help? How can CADTH help with some of these challenges that we heard about today?
Well, one way it can help is it can highlight the very different utilization of equipment across the country. So for instance, we have very expensive equipment like MR that are expensive to purchase and maintain and run. And in some places they run for 8 hours a day, and in other places they run for 24 hours a day. So do we need new equipment? And I'm not saying we don't. Or do we need to really look at how we use the equipment we have now and optimize what we've got?
I think it's really useful, particularly coming from a smaller province where we don't necessarily have the newest and greatest technology. We have great working machines of what we have, but we're perhaps behind the times. For example, we don't have PET-CT, and I don't see us getting it anytime soon. And we were later getting MRI. And one of the things that this does for us is it allows us to see what's coming down the pipes, what's becoming commonplace, what is becoming the everyday in imaging, to see where perhaps we are going to be going in the coming years. For example, like when we moved along to and installed an MRI machine, you know, are we going to watch PET-CT over the next few years? Is it going to become commonplace enough that perhaps we might acquire something like that?
For us, I think it's important that we take the opportunity. Lisa mentioned that there's an opportunity for us to dive in a little deeper. And a conversation that I had with Harindra a couple of weeks ago is that seeing these, you know, X number of machines and X number of exams, there's no context, and it's difficult to say why some units can put through more exams than other, or how it is that one province is able to do these, you know, certain studies and another one can't. So what we need is some context and diving into that data. So if it's possible to work with CADTH to that granularity to help us have, to tell a story, a narrative, I think that would be very helpful. And if that data isn't currently there that we can get to, then maybe that's a place for the next iteration to be able to take it to that level. Thank you.
Thank you. Any final thoughts? We have 5 minutes left.
I was looking at the data that was presented today, putting Canada apparently certainly not at the top of the pack in terms of how much equipment we have per population, but I do think that we have to agree and acknowledge the fact that more is not necessarily better. It may be better, but it's not necessarily better. Our friends south of the border always have a view that, you're just not there if you don't have the most magnets in your city. And that is it's a certain way of doing things, that bigger is always better. It isn't. We need data. We really do need data. We need to continue to research what of these technologies really is having an impact on people's lives. Having an MRI just to have an MRI is not where we want to be. But on the other hand, if you need an MRI, and there's evidence that the MRI is going to help, we need, and we're obliged as a society, to have that equipment reasonably nearby and reasonably accessible. So that's why appropriateness is everything to us. And then we see wait lists and numbers of machines per 1,000 population in the context of appropriateness. And that's really what we're trying to achieve.
Just to follow along to what Greg said, in terms of what we have available, we have to consider as well that all these machines are very costly. And with the increase in the demands of the healthcare system, we really have to consider, what can we do to, what are the best imaging techniques for particular things. Sorry, I'm having a total blank.
It's okay. Can I read that for you?
But, the demands on the system do increase. I know when I started an MR on PEI in 2006, we did a maximum of 12 cases a day. We now do in the range of an average of 30 cases a day. And so in 12 years, that's the increase. And how do you continue to sustain that increase? So we really have to look at where we're going with imaging and what's really appropriate.
And one of the things I think we really need to get to is are we making a difference in the health of our patients? We have to get there, because the bottom line is we've talked about the fact that more isn't necessarily better, and that there are limits to resources and what we can reasonably do. So bottom line is we can do more and more, but if our patients aren't healthier, then I think we need to stop and look at what we're doing to make sure that what we're spending is valuable.
Thank you very much. Those are very interesting thoughts and comments. And that concludes our session, unfortunately. I wish we had more time. But I'd like to thank everyone in the room, online, our panelists, and all the CADTH staff who helped make the event possible today. So please join me in a round of applause to thank the panelists.